evening to everybody. Thank you for staying up this late to join our session. And this is a very exciting session titled Sexual and Reproductive Health, Broadening Access to Care During COVID-19 and Beyond. And I'm excited to say that we have a wonderful, experienced group of panelist women here to join us to discuss this subject. But before we do, I would just like to go back and say that access to SRHR has been a challenge even before COVID-19. However, we did make some, phenomenal strides. We saw calls to action such as the FP 2030, 2020, and 2030, which saw countries moving forward this agenda. We also saw innovations such as the DMPA-SC self-injection, for hormonal contraception for women, which I was very personally excited about and rolled out in my own country. And this meant that women could own and use and improve the access to contraception and family planning. Apart from that, there were also community workers who were allowed in certain countries to go out in the community. And this was one of the innovations to improve SRHR access. However, enter COVID-19, and COVID-19 disrupted the healthcare system, but totally also almost decimated all the efforts that were made around SRHR access. We know, for instance, that the UNFPA report said that in 2020 alone, 12 million women lost access to family planning services due to disruptions caused by COVID-19. And what this did is that it led to millions of unwanted pregnancy and thousands of preventable maternal deaths. But one thing, amidst all this darkness that we faced is that we saw frontliners rise to the occasion. We saw healthcare workers and advocates and activists working tirelessly to bring these essential services to communities and to the fore. We saw, innovations being used. We saw telehealth being used to treat patients. We saw the conducting of virtual trainings for healthcare workers, and we saw activists promoting self-care approaches, to increase access during this time. So people and organizations found innovative ways of mitigating the pandemic's disruptions. So what do we want to do today? So today, we aim to explore the creative and perhaps new solutions that organizations are using to deliver essential sexual and reproductive healthcare services during COVID-19. And without much delay, I would like to introduce our wonderful panel today. So please join me in welcoming our panel. And I'd like to introduce to you Latanya Mapp Frett, and she is the president of the Global Fund for Women. I would also like to welcome Diana Abbas, and she's a global activist and SRHR specialist, and also the former director of MARSA, a sexual and health center that's actually based in Lebanon. Next, I would like to welcome Mehreen, and I hope I said that correctly, Mehreen Shahid, and she is the founder and chairperson of Safe Delivery, Safe Mother, an organization that works in the hardest places in Pakistan to reduce maternal mortality rates in Pakistan. And then finally, I would also like to introduce Margaret Bolaji-Adegbola, and she is the executive director and founder of Stand With a Girl Initiative, an SRH organization that is based in Nigeria. So we have a rich panel, and we're literally spread right across the globe. So this promises to be a very exciting discussion. So I've already talked about the impact of COVID-19. I want to dive deep into this and ask you, I'm going to start with you, Diana. So what are some of the obstacles that you faced in your work to provide SRHR services to women in Lebanon, as well as to the LGBT community and other vulnerable groups? Please tell us, some of the obstacles you encountered and how you adapted to them.
Thank you, Namwinga. Unfortunately, in Lebanon, COVID doesn't come as a singular crisis. It comes along with the political and social unrest that started in October 2019 with the Lebanese revolution. And it's also hand in hand with the economic crisis that Lebanon has been facing, and the devaluation of the Lebanese pound and it losing more than 90% of its value. Up until August 4, 2020, when we had the major Beirut explosion where over 200 people died and many lost their homes and jobs. So throughout all of these problems, as a center, as a sexual health center, we were already struggling with maintaining SRHR at the top of the priorities list for our target populations. And COVID came at a time when, during the beginning of the pandemic, when nobody had enough information, you had to deal with your personal stress and the stress of everything that's going on around you and taking care of the community that you're serving as well. So primarily, we had to disseminate the information about the prevention of the virus, and especially when it comes to people living with HIV, there was very little information in the beginning about the relation between HIV and COVID, and this is where we had a lot of questions from our beneficiaries. And we had to wait until WHO and UNAIDS, for example, released some information and some statements that were rigid, that we had to translate into information that was accessible and easily understood by lay people who did not have a medical background. We also saw that people had a fear of mobility. They couldn't get around because they were afraid to get the virus. And that's how we had to use online resources such as telehealth, like counseling online, and health promotion to increase people's interest in prevention and keep promoting sexual and reproductive health as a priority, despite the fact that people were afraid to go out. And we also faced major problems with the refugee camps, where your main source of prevention was maintaining your hands clean and masks, and there was no clean water in the refugee camp. So in this sense, we had to work a lot with our partners to prevent COVID from spreading among these small communities, and maintaining access to sexual and reproductive health, while at the same time protecting the medical teams that were working on the services at the time.
That's incredible. I like what you said, Diana, about the fact that COVID does not operate in isolation, and just listening to all the complexities and what you have to go through to deliver SRHR services is commendable. So thank you for that. I'm going to now jump to Mehreen. And I was going to ask you, delivering SRHR in your very hard to reach areas with high mortality rates in Pakistan, can you give an example of a creative solution that you deployed to reach these populations?
Right. So, the populations in the areas that we work in, it's very important to understand that there's very limited connectivity and digital competence, which is why I'm mindful of the fact that we don't have that one solution that we can apply. That's one issue. The second issue, when you talk about creative example or solution that we've come up with, is also to explain that the background of where we work is these are hard areas. They're culturally difficult to get through to. There are a lot of myths and beliefs that we struggle with or grapple with, and we have to be very intelligent and smart in tackling them. So it's not a conversation between peers. It's not a conversation between people, let's say, with the same intellectual level. So you have to come to a certain level of, low literacy, low resources, and try to understand where they're coming from. So the areas that we go to are literally, we've been to like hilly mountainous terrains where it's very cold, or we'll go to, even if we go to some plains right now, we're in South Punjab, which is one of the most populous parts of the country, where, there are different communities and populations with different beliefs. So what we do is, in our engagement, there are a couple of things that are very important. One is that we equip birth attendants and health workers, because they are the essential link that go to households and doorsteps. that is where we are not present. These are women who are going to be making meaningful visits. They know about their communities. That is one thing. Second, when we equip them with the right skill set. So we engage them through the community in a way that the community responds. So we use a lot of pictorial tools, in the local language. So it's very important. That's what we use. Thirdly, what we do is we also teach them specific ways of how to overcome challenges. As an example, with sexual and reproductive health, one of the common beliefs here is that if you take a placenta at home, it is a sign. It is a good sign, and it will give you more sons or more children. So it's very infectious, and they fight. They literally, patients will fight and take it home. So we teach them exactly how to counsel these women, how to tell them it's infectious, it is dangerous for their generations, it's dangerous for their children. So in their language. And, in these low resource settings, what is important is that connection, that personal connection. So how we kind of back that up is we talk to them about through word of mouth, and we say within your community, we spoke to XYZ person who you already know, and we explain to them and they listen to us. So that response, gets a very positive saying in the community, that the birth attendant really addressed my issue. She saved my, my daughter-in-law's life. She prevented excessive blood loss. So that builds a positive rapport. And then, using these pictorial tools. And lastly, most importantly, we engage the men of the community, the decision makers. So this is the approach that we're taking, right? Coming down to their level, engaging with them personally, using pictorial tools, giving examples from within the community. I cannot emphasize this more when I talk about the work that we do. We do not need to come up with fancy solutions in these low resource communities. We need to think from within the community. They have immense respect amongst each other in this community. And that is what we need to leverage. And that's what I've learned. And that's how we basically practice in the field with our examples that we give to ensure uptake and, most importantly, acceptance.
Mehreen, I think that is so important, what you just said about not necessarily using fancy tools and understanding what works in these communities, as well as the personal connection is so important, particularly when you're talking about something as sensitive as sexual reproductive health. So thank you for that. I'm going to now jump to the funding perspective, and apologies, the sun seems to be coming into my face. I don't know why, but apologies for that. Funding is so important, Latanya. COVID-19 was not a planned pandemic. It wasn't planned, and it came upon us. So as a funder, could you please tell us how you responded to competing priorities and other challenges that were posed by the pandemic? If you could tell us a little bit about that. And in what ways did you adapt funding strategies to ensure continuity of services?
Absolutely. And thank you, Namwinga. It's a pleasure to be here with all of you. And I'm going to go back to what our other colleagues have talked about. But I just want to start, when we talk about COVID, we're usually citing statistics like WHO, the World Health Organization, that it's disrupted 2/3 of, I think they did a survey of 103 countries, and access to family planning and contraception services were decreased by 2/3, which is startling, especially as Diana said, it didn't start with COVID. This access to services has always been a bit of a challenge for us across particularly the Global South, but I'll talk about the Global North in a minute too. But we like to think about it at Global Fund for Women that COVID is providing this opportunity to address longstanding inequalities. And so as governments consider how to achieve a more gender equal recovery, it's almost inherent that they have to ensure access and rights to a full array of reproductive health services as a piece of that puzzle. And to achieve a gender inclusive COVID recovery, women will need to access these essential healthcare services and agency over their own futures, especially and including when to have children. And this is what we've been seeing with our partners. But we're also at a major inflection point, and I'm calling in from the US, and we've had the recent repeal of the global gag rule, which is, a US imperialist and racist policy that further disrupted these health services. It stigmatized abortion. It made it harder for civil society organizations and coalitions to operate. and the effects were long lasting. And so, you know, now grassroots gender justice movements, as we've been talking about, are doing the crucial work to build back from the harmful effects of policies like that, so that we can have lasting and sustained change. And this is what we see as the opportunity with COVID, the ability to be able to support efforts. And for us, that means increasing funding and resources. And rights matter, but also access matters in sexual and reproductive health and rights. And I think most of us are familiar with what happened in Texas earlier this year when a state legislature in the United States passed a law which roughly amounts to a total abortion ban in that state. But, you know, and this is during COVID, right? But earlier we saw, or I think just after that, we saw in Mexico, they moved in the opposite direction. And so while we're seeing some of this regression, this patriarchal regression in some places, we're also seeing progress on access to sexual and reproductive health. And this year alone, there's been progress in Argentina, South Korea, Thailand, India, and again, Mexico. But, you know, again, COVID has brought into sharp focus that access to reproductive health services aren't just limited by restrictive legislation, but also can be limited by crises. And like the COVID pandemic, which really did cause non-essential health services, that's what they called it, to be suspended in many places. And there are other factors too. For example, onerous and unnecessary administrative hurdles have been put in place under COVID, lack of regulation and coordination, widespread beliefs that abortion is completely illegal when it's not. And we must be ready to address all of these obstacles as they come. And so we know that means that grassroots funding responses to these crises are increasingly important under these circumstances. And so at Global Fund for Women, we have a crisis fund that supports partners during crises, including and especially COVID-19, but also, I think, as Diana mentioned, under political upheavals in the wake of natural disasters. So right now we're partnering with local feminist groups that are responding to the urgent needs of women and girls and that have emerged during the COVID-19 pandemic. What has been important is what our colleague Mehreen was saying is that you have to listen to what's happening in the community. You have to leverage the relationships and the trust that's already been there. You can't start new things because of a crisis, and COVID-19 is no different. And so since establishing our crisis fund in 2014, we've awarded $6.5 million to close to 300 organizations that are responding to crisis in 60 countries. And our grantee partners, like I said, are uniquely positioned to lead the crisis response because of their relationships with the communities and their ability to get resources to those who are often overlooked by the mainstream response. And that includes widows, Indigenous people, LGBTQI people, displaced communities, and those living in marginalized, particularly in remote locations. So we anticipate, that the crisis work will grow. It is currently more than close to 20% of our annual grant making budget. And this work, didn't begin and won't end with the COVID-19 pandemic. And we can't only be going from crisis to crisis, right? So our work also must be sustained and focused on long-term change. And so, for example, at Global Fund for Women, we've been supporting a growing movement fighting to advance rights in East Africa. So what was good to see was that our grantee partners in this region is no different than others, but in that region quickly pivoted their funding towards COVID-19 response. And they could only do that because our funding is long-term and it's flexible and it's unrestricted. And so we are using this moment to be able to continue to talk to our organizations, to other philanthropists, let me just say, and other organizations that provide grants to really get them to kind of move back away from this very restrictive funding that means that when a crisis happens, when a COVID-19 comes up, that they can't actually move those resources to where the community most needs them. And in this case, it was a response to COVID-19. So again, for us at Global Fund for Women, we think about feminist and trust-based funding, meaning that you give funding that's long-term, flexible, and unrestricted. And so that's where our moment is. And I'll stop there and come back to other things later.
Thank you, Latanya. I think we heard some some critical things there. I mean, one of them being COVID, providing the opportunity to address, some of these gaps, and not necessarily seeing it as a barrier, but, looking at it from a different angle as an opportunity to address this. And I think you also brought out the important point of being able to pivot funding and also funding grassroots entities, because these are the ones that work. Again, we've seen the impact of policy on provision and access to SRHR. We all understand what the global gag rule did, and the fact that these effects are going to take some time before they're undone. So thank you for bringing the funding perspective to the table. I'm going to now move to Margaret and say, Margaret, we know the importance of data. Data informs our programs, data informs policy. So I'm going to ask you, Margaret, the importance of having disaggregated data around adolescent sexual reproductive health activities. Could you give us an example of how your work was disrupted by the pandemic and how you were able or unable to apply your data and to your work during the pandemic?
Yeah, thank you so much. And for me, really, when talking about data, it's always, while we assume everyone knows the importance of having a data-driven program, and whatsoever thing or people that you don't count will not count. And, it's okay to just say, oh, we have women of reproductive age really hit by COVID-19 pandemic, there is stock out, there is this, but beyond just saying women of reproductive age, we also need to then bring this data disaggregated by age and say, oh, adolescents 10 to 19, young people 10 to 24 have the special needs. Again, understanding the fact, just like with every human, it's adolescents and young people come in their different diversity. So whether you're talking about adolescents and youth with disability in urban areas, in peri-urban, in rural community, with their sexual orientation and all of that. So this, of course, underscore why it is important to really have disaggregated data so that we're really meeting their needs. I'll give a quick example. So with all of the pandemic, just like every other panelist has mentioned, there was really issue around access. It has always been there, no thanks to social cultural barriers, providers bias, and all of that, even the government policies that are not being implemented, because I tell you, in Nigeria, we have absolutely beautiful policies in papers, but they are not being implemented. Again, if we're not using the right data, it will just be there and not really make sense, really. So, when all of this came up, we as an organization, Stand With a Girl initiative, initially it was, oh, the pandemic, everybody went back to their shelves. And for me, it was, we were just hearing news, feeling bad about people losing their lives. We wanted to be alive and safe, but few weeks into it, I just had my baby, and then I wanted family planning method. And then I spoke to a provider that I know in the space. So of course, that already, because I'm in this field, should naturally give me an edge over another young person who doesn't have access to this kind of person. But to shock me, I couldn't get the exact method, even after the balance counseling and all of that I wanted, because some of those nurses had to be relocated to a special department because we were responding to COVID issues and all of that. So while that hit me when I could not access. And then I said, oh, Margaret, a lot is happening at the community level. So we need to do something. While we could not particularly reach adolescents and young people who didn't have access to mobile phones, we had to then begin to generate data from the different youth groups that were already on WhatsApp particularly, and then say, what does it look like? What are the challenges? And then we begin to see that, oh, yes, women of reproductive age 15 to 19 have issues around stock out because then movements were restricted, but it was also, it was special again for adolescents and youth, because even if you then own up and say, I'm going to be okay, I will dump COVID, I will go, of course, following all of the protocols. You get to the health facility, then someone tells you, we have stock out, we would rather give it to an older person. Again, they're asking you, how many children do you have? Oh, you have none. You can wait, we would rather focus on someone who have more children and all of that. So while we were undergoing this qualitative kind of research, it really helps us know what the challenges were. And then we were beginning to link young people to services as we could as an organization. Another thing that stood out for us while speaking with young people, really wanting to understand what the issues were, was also a lot of myths and misconceptions. So 100%, I agree that COVID exposed us to a whole lot of opportunities, like using the digital platform to be able to reach young people, adolescents, and even older persons. There were a lot of junks, with the internet, it comes with the good, the bad, and all sorts of information. So you could even hear people say, oh, since I can get a condom, I then use overdose of malaria drugs. That's crazy, So there were a lot of myths and misconceptions. So we had to sit as an organization and say, oh, it's time to really develop materials that can address and dispel this myths and misconception on SRHR as an organization. So for us, that was how it hit us, that even while we have some data at the global level from WHO, from UNFPA and all of, we didn't have localized data to really help us speak to the issues that young people were passing through at the wake of the pandemic.
Great. Thank you. Thank you, Margaret. That was an elaborate answer, and I totally hear you on the data. One thing that struck me, though, was that you talked about collecting data of 10 to 14-year-olds. I think Margaret has just dropped off. And it will be interesting to understand how other countries have dealt with collecting data around SRHR within that age group. However, I want to look to the future, and I'm going to move to you, Latanya. You had talked about a couple of interesting movements, but I want to find out how grassroots organizations, who are so important in catalyzing movements, how they've adapted, during the COVID-19 response. And I think an example that we all would want to hear about an example that we would all want to hear about was what happened in Mexico, and how the green wave paved the way for change in Mexico. Could you tell us very quickly your experience around that? You're muted, Latanya.
Yeah, sorry about that. I was trying to come off of mute. And I'll talk a little bit so that we are quick, but we've seen it again and again, right? Feminist movements can do so much. And I implore all of us to step up and to learn more on how we can support them to lead. Women and girls are already mobilizing in revolutionary ways against harassment, discrimination, and violence everywhere you turn. And so, so Black Lives Matter to the Red Umbrella Movement to Me Too, Ni Una Menos, from Lebanon, as our colleague was saying, Sudan, Iraq, Chile. We could just go on, but people around the world are demanding a more equal world. And they're doing this through movement building. And feminists are right there on the front line. And these movements are both online and offline. And they're building this broad-based and intersectional constituencies around the world. And so Global Fund for Women believes that this kind of transformational social change comes from movements led by those that are most impacted and marginalized. So we're seeing this across our work. For women, it's, we're funding these grassroots gender justice leaders because they are creating this long-term change. And this kind of funding, as I said, works. We've seen it in research, we've seen it in practice, and we don't need to, delve into any more than that to know. And again, I said, this is our moment because I think we need to step up now. And in this time of COVID, in the midst of so many intersecting crises in the world, including the devastating climate crisis and political unrest in countries around the globe, we can all step up by giving activists the funding they need to drive transformative change. So we talked about it, but funding local leaders to pursue the change they seek and the work that they prioritize. And so when we talk about what's happened in Mexico and Argentina and other places where movements, particularly for sexual and reproductive health, are working, it is that seed funding that Global Fund for Women gives. And it's not it's not a directive kind of funding saying, okay, this is our strategy that we built here in New York or San Francisco or DC or whatever, and this is what we'd like you to do. Instead, we take it another way, and this is what happened in Mexico. Activists who were already on the ground, already had strategies in place, already been organizing and mobilizing, said, how can we get further support? And we at Global Fund for Women don't feel like they should have to come looking for us. They shouldn't have to be looking through like hundreds of requests for proposals to try to get money. We should find them. I think funders should find them. The work that they were doing in Mexico was clear. They were already on the ground. They were already moving. And so for Global Fund for Women, it wasn't about asking them to, fill out a proposal and send us, 100 pages of how they do their work. But it was about sort of going to them and building a relationship with the movement and saying, how can we provide you support? And yes, that meant a check over a number of years because this didn't happen overnight, but it also meant other kind of resources that come from being hand in hand with partners and local communities and saying, where can we bring you partnerships strategically that are going to help you? How do we bring you advocacy? How do we amplify what you're doing? And so go ahead. Am I coming?
I was going to say that this is fantastic.
Okay, you want me to stop here?
This is fantastic. We have a couple of, this is incredible. We have a couple of minutes left. And I just wanted to say, I appreciate what you said about grassroots movements. They're happening everywhere,
yes.
With COVID or without. And the
Absolutely.
fact that we need to go to these grassroots movements and flip the way funding is done. So that's key. But I just wanted to do one quick last round robin with all of you in the
Absolutely.
couple of minutes that we have left, because this has been so incredible. And I want to ask all of you, and I'm going to start with Diana. Diana, what is the one thing you would ask the next generation of sexual and reproductive health leaders to do? And apart from that, I'd like you to put that in the context of you work in Lebanon and it's a very challenging environment. So I'd like you to frame your response around that question and around your setting.
Thank you, Namwinga. In Lebanon, when you're working on sexual and reproductive health in a context where sexuality is not even discussed in curricula and you don't have access to information or education, homosexuality is criminalized, and it's just a very conservative space. I would like to go back to the research aspect as well. And I would like to mention that we base all of our advocacy campaigns on research. It's the research that's being conducted at the center and through our partnerships on the ground with other local organizations. And this is how we build our advocacy to protect ourselves as an organization working on such a sensitive topic. In addition, I would also like to highlight the importance of partnerships and network building. I think it's very important to rely on every ally that you can get in such an environment, such as other local organizations or academic institutions. And I can suggest the work that was done after during COVID and after the Beirut explosion, when we all came together as organizations to create a relief fund for the LGBTIQ community who were facing a lot of gender-based violence at home and in the street, and for those who lost their jobs or homes or who were injured in the explosion. And for this work to happen, I think it's important to have a intersectional feminist lens when it comes to the work that you're doing, whether it's on the work that we're doing today or the future leaders, because that's the only way for us to create access to sexual and reproductive health and ensure that everybody's rights are being achieved.
Thank you, Diana. I heard networking and partnerships are so important. So I'll ask you the same question, Mehreen. What is the one thing that you would tell upcoming leaders in sexual and reproductive health? What's the one thing you would ask them to do?
So, you know, even when I have this conversation at home here with organizations that are working in Pakistan, the conversation oftentimes I try to frame the conversation in a way that there is no one size fits all, right? There is no such thing as innovation is equal to digital competence. There is no such thing as connectivity is the solution to everything. So what I say is the communities that we work in are rural, remote, they're extremely challenging. The solutions need to be equally at par with that challenge, right? And that basically means thinking about how to get to them. You know, when we talk about use of SRHR, sexual reproductive health, we're talking about not only accessibility, we're also talking about acceptance. So there's an additional challenge that we face. And, you know, to the conversation that's being had here, it's very important to support these grassroots organizations. The work that we're doing are at that community level, right? So I would ask leaders that go into these communities, try to truly understand them, try to understand what is the moral, social, political fabric of these places and why they resist or not, right? And what can you do to overcome that? Once we understand that, I have personally seen in Pakistan, and I think this applies to a lot of other developing country setups as well, you will often see local NGOs, grassroots organizations, and CSOs doing a lot more work than so bigger international organizations. And this is not to say that they're not working. There's like, if I'm working here, there's limited red tape. We don't have that kind of bureaucracy, which comes with a lot of, you know, those international setups. Many times I think funding becomes a challenge for us, right? You're looking at sustained, flexible funding to be able to do the work that's needed on the ground. So I ask leaders to look into these elements. These aspects are very important. And also trying to understand who are those key enablers on the field. Community health workers, birth attendants are those really at that critical point where we don't reach. They're at the point, they're the front line at access. At times, they're the only ones who are there, right? There are times, so I often say in my training sessions, I say, I'm not saving lives, you are saving lives. You are the ones we are enabling. And we have to equip you in a way that you're able to do it in these challenging environments. And if we take the case of Pakistan, we're grappling with COVID, we're grappling with polio eradication, we're grappling with dengue. So, you know, these health workers, they're the backbone. They're literally thrust forward with everything that comes up. So I would request and look at leaders to look at all of these aspects and to sort of reimagine and look into your local context first and foremost.
Great, thank you. So it's not a cookie cutter approach. You have to look at your circumstances and create a specific response to your circumstances. So that's great. Margaret, you have 30 seconds to give us a minute to give us your one key message to upcoming sexual and reproductive health leaders. What would you say?
Okay, so again, I know this over time seems to now sound like a cliche when you say you have to meaningfully engage young people. But again, that is what we need to do. And when we talk about meaningfully engaging young people, it means right from the research stage to the design, to the implementation, to monitoring and evaluating and accountability. So we have to ensure that they are meaningfully and equitably engaged in all that we do, because only then can we then begin to have youth-friendly health services, begin to utilize the power in technology. Young people, adolescents are very innovative. We've worked with them. We're currently doing a project where they are disaggregating data, and we actually call it data made simple. These are youth data advocates saying this is how we want to simplify data so that it can be used for decision making. So we need to invest in the young people, put in the money. We know it works. Also put in necessary tools and mentorship. It's also very key, even as we work towards an equitable partnership with young people, youth-led organizations. Thank you.
Great. Thank you, Margaret. This has been an absolutely fantastic panel. We didn't have enough time. I can't believe the 45 minutes passed by so fast, but I would really like to thank all the panelists for the wonderful experiences. We've heard from the funding aspect. We've heard from Diana and her experiences in Lebanon. We've heard about community workers, and we've heard about the importance of data and young people. To close out the session, Latanya, I would like you to have the last few words on what your take is to send us out. And as we go out, I'd just like to remind everybody to navigate back to the agenda page where we will have an opportunity to join the networking room. But I'd like Latanya to have her give us the last words on what you would have our sexual reproductive health leaders do. What would be your advice to them?
Thank you. And I just want to thank the panelists, Diana, Margaret, Mehreen, and of course you, Namwinga, for leading us through this dialogue. And I think they've said it all. I just want to say that gender justice movements give huge social returns, yet they receive a tiny investment. Less than 1% of all gender equality funding reaches the grassroots. We can't defund this work. We need to increase this work. And we need to make sure that movements are consistently supported. So thank you for the opportunity to be here with all of you today.
No, thank you so much to all the panelists and for all those who tuned in. This has been a fabulous session. Thank you so much again to our panelists, and we look forward to you joining the next session. So with that, I would like to say bye-bye and to apologize for the African sun that just fell onto my face, but